Dr. Ben Silk has over 25 years of experience in public health surveillance, field epidemiology, and applied research related to infectious disease prevention and control. Dr. Silk began his career in public health as a Peace Corps volunteer in El Salvador. He has worked at the state and local levels for health departments in Georgia, California, and Louisiana, and programs ranging from influenza and tuberculosis to invasive bacterial and foodborne illnesses. He received a Bachelor's of Science in Physiology from the University of California, Davis in 1995, an MPH from Tulane University School of Public Health, and tropical medicine in 2001, and a PhD in epidemiology from Emory University, Rollins School of Public Health in 2008. In 2010, he completed training as an epidemic intelligence service officer assigned to the respiratory diseases branch at CDC, and currently is the acting surveillance and prevention branch chief in CDC's proposed new COVID and other respiratory viruses division.
Okay, thanks so much for the kind invitation to participate in your meeting. I'm Ben Silk, and I'm going to be providing an update on SARS-CoV-2 variant and the epidemiology of COVID-19. The data I have to share today are current through August, so I thought I would just start by reminding everyone that CDC has a COVID data tracker where you can find the latest and greatest surveillance data on a dashboard that's publicly available. So first, let's talk about the changing landscape of circulating variants. And this is historic data showing from January 2021 to January of this year, how that landscape has changed. And that's been a distinguishing feature of this pandemic. Prior to July 2021, many variants had circulated simultaneously, while the alpha variant in the teal color rose to predominance. However, this changed with the rise of the Delta variant in orange, which displaced previous variants. And then, of course, there was the rapid rise of the Omicron variant in purple in December of 2021. Just a little bit of technical background. We wanted to run through the characteristics of the SARS-CoV-2 Omicron variant. There are at least now 5 main sublineages numbered BA1 through BA5, which are further divided into hundreds of sublineages. And Omicron in particular has been shown to have increased transmissibility, but decreased relative severity compared with previous lineages. As you can see in this graphic, there are many mutations in the spike gene, and those are associated with lower vaccine effectiveness and reduced efficacy of some monoclonal antibody treatments. One thing you'll find in the COVID data tracker are the estimated proportions of SARS-CoV-2 lineages in the United States. Here's a national view showing recent trends in weighted estimates of variant proportions and what we call nowcast projections of circulating SARS-CoV-2 lineages. These data are presented by week of specimen collection. The Omicron sublineages are depicted in different purple, pink, and teal shades, and have been over 99% predominant for many months now. The BA2 sublineage, which is in lavender, and the BA2121 sublineage in pink have been displaced by BA4 and 5 sublineages, which are in teal and blue shades. And for the week ending August 27th, BA5, which is the dark teal, comprised almost 89% of sequences. And then one we're watching, BA4-6 in blue, comprised 7.5%. And lastly, BA4 in light teal was 3.6% nationally. Here's a figure showing the estimated numbers of COVID cases reported by variant, and these are estimated numbers of reported cases by variant based on the variant proportions which are then scaled to the number of nucleic acid amplification tests, or NATs, including PCR tests, which are the sampling frame that's used for genomic surveillance and the weighted of estimates. I like this graphic because the trends highlight the more recent waves caused by the BA2 Omicron sublineages in pink and lavender, and the BA4 and 5 sublineages in teal and blue, and how they've been much smaller than the initial Omicron wave related to the BA1 sublineages in the darker purple colors. Here are nowcast estimates again of the variant proportions by HHS region. This map shows the relative proportion of Omicron sublineages across 10 health and human services regions, and BA5 in teal represents the majority of circulating lineages in all regions during the most recent week, which was through August. Next, I want to shift and talk about trends in COVID-19. And first, we'll look at the daily trends in numbers of COVID-19 cases at the national level. This graph shows trends in the daily numbers of cases reported in the US since the beginning of the pandemic. The number of cases associated with the Alpha variant was relatively small compared with the Delta and Omicron variants. Nationally reported cases started increasing in April, and then leveled off in June and July and have been decreasing in August. And as of August 30th, there have been cumulatively 94 million COVID-19 cases reported in the United States. And certainly many more than that after you account for underreporting and underascertainment. Here are daily trends in reported COVID-19 cases, and also percent positivity as the 7-day moving average of NAT tests at the national level. The graph shows the daily number of reported COVID-19 cases overlaid with a 7-day moving average of percent positivity, which we're using as a marker of transmission intensity. The trends align remarkably well in late 2020 through early 2022. But starting in May, you can see the trends began to be uncoupled, diverging, with the numbers of reported COVID-19 cases leveling off, while NAT positivity in late July increased to a high of 20%, related to increasing transmission, decreased provider-based testing, increased at-home testing, and which is largely resulting overall in more underreporting of an underestimation of reported cases. However, most recently, NAT positivity and case counts have decreased during August, which suggests a decrease in overall transmission. The takeaway from this slide is that up until relatively recently, case surveillance for COVID-19 was a pretty good marker of activity and transmission, but as you can see here, due to several factors, that has changed. And so we need to probably be looking at other sources of data in combination with case surveillance. Here are weekly trends in COVID-19 associated hospitalization rates by age group. And these data come from COVIDnet, which is active surveillance in several sites across the United States for the period of March 2020 through August of 2022. These are weekly trends in the rates of COVID-associated hospitalizations by age group. And you can see that the higher hospitalization rates have always occurred in older adults 65 years and older, followed by adults 50 to 60 years old, that's shown in purple, and then younger adults 18 to 49 in blue. On the right, you can see that since April, in the magnified view, hospitalization rates have increased relatively more among older adults 65 years and older compared to younger adults who did not see large increases in hospitalization rates. And then these are hospitalization rate ratios by age group, still COVIDnet data. And these data were recently published in an MMWR if you want to read more about that. The graph is showing the hospitalization rate ratios by age groups, and the youngest adults 18 to 49 years of age are the reference group. And so the different color bars relate to different time periods through May, with Delta in gray, Omicron BA1, the first Omicron, in light blue, and Omicron BA2 in dark blue. And over time, there's a widening gap between hospitalization rates in older and younger adults. And then the other main message is you can see that age remains a strong risk factor for severe COVID illness as measured through hospitalization here. These are characteristics summarized of hospitalized adults in the COVID-net data. This is the same MMWR I'm referencing if you want to read about it more. And it shows that the median age of patients with COVID-19 associated hospitalization increased across the 3 time periods, while the percentage of hospitalizations that were likely COVID-19 related decreased slightly between the Delta and Omicron periods. The percentage of cases with underlying conditions, immunosuppression, and those residing in long-term care facilities increased, while outcomes related to clinical severity decreased. These trends are likely related to a combination of increasing vaccination, waning of immunity, changes in COVID-19 treatment, and differences in variant severity over time. Here's a slide showing age-adjusted rates of COVID-associated hospitalizations among persons of all ages by race and ethnicity. And the graph shows a 3-week moving average of age-adjusted rates of COVID-19 associated hospitalizations by race and ethnicity. Throughout the pandemic, American Indian and Alaska Native people, which is shown in light blue, Black people, shown in navy blue, and Hispanic people in red, have been disproportionately affected by COVID-19 associated hospitalizations compared with white and Asian Pacific Islander people, shown in gray and green respectively. The scale of these disparities has decreased after the Omicron surge, but hospitalization rates are still highest among American Indian, Alaska Native, and Black persons. Shifting now to deaths, here's a figure showing daily trends in the numbers of COVID-19 deaths in the US. And this is the daily number of provisional deaths reported to the National Vital Statistics System since the start of the pandemic. NVSS data come from death certificates and are generally considered to be more reliable than the death data reported through COVID-19 case surveillance. As of August 27, there have been over 1,042,000 deaths due to COVID-19 reported cumulatively in the US, and Omicron has caused a sizable number of deaths despite decreased relative severity, simply because of the high numbers of cases overall. Here are weekly trends in COVID-19 mortality rates by age groups. And these are, again, NVSS data. The data show higher mortality rates are consistently observed in older age groups, most notably on this graph, among those 75 and older, 65 to 74 years old, and those 50 to 60 years old, as shown in brown and pink colors. And similar to hospitalizations, we've observed a recent increase in death rates for older ages, particularly patients 75 and older. Here are weekly trends in age-adjusted COVID-19 mortality rates by race and ethnicity, still the NVSS data, and these are provisional death certificate data, and age-adjusted. And so the data here are showing higher mortality rates observed throughout the pandemic among Black people, shown in navy blue, American Indian, Alaska Native people in light blue, and Hispanic people in red, compared with white people shown in green. So I wanted to shift a little bit and also recognize that in addition to hospitalizations and mortality, COVID-19 is associated with significant disease complications, particularly multi-inflammatory syndrome in children and post-COVID conditions. Since May 2020, Almost 9,000 cases of MIS in children and 71 related deaths have been reported in children related to this condition following COVID-19. And according to a recent MMWR article published by CDC, 1 in 5 COVID-19 survivors aged 18 to 64 years old and 1 in 4 survivors over 65 have experienced at least one new chronic condition that might be attributable to previous COVID-19. Adult COVID-19 survivors also had twice the risk for developing pulmonary embolism or other respiratory conditions. And the study used electronic health records to study a population who received medical care for COVID-19, possibly indicating they had more severe symptoms that could result in higher rates of PCC. So just a caveat to these estimates to keep in mind. And here's a slide showing trends in daily trends in MIS overlaid with COVID-19 case reports as a 7-day moving average. The MIS cases are the the solid blue line, scaled quite differently, of course, than the COVID-19 case report data. But you can see that they often track together, although, of course, the magnitude of the trends is substantially different. Okay, now let's change and try to factor in vaccination status and understand what that key intervention means with our trend data. And so first, overall, as of August 24th, we estimate that almost 224 million people in the US have been vaccinated with a primary series, which is 72% of the population ages 5 and older. 49% have received a first booster dose, and 34% of people ages 50 and older have received a second booster, suggesting that uptake has been relatively low with booster doses recently. Despite the overall progress, there are important differences remaining in the primary vaccination coverage by age, as well as race and ethnicity and disability status, which are also priority populations for vaccination. I wanted to describe a little bit more about how we're collaborating with 31 public health jurisdictions to monitor case hospitalization and death rates by vaccination status. These 31 jurisdictions cover about 70% of the US population, and the thing they have in common is the capacity to actively link case surveillance data with immunization registry data to ascertain vaccination status, as well as vital records to ascertain outcomes and death. And then with COVIDNet, again, an active population-based sentinel surveillance system in 99 counties and 14 states, about 10% of the population. These same active linkages are happening, which allow for ascertainment of the hospitalizations by vaccination status, as well as capture of key clinical data through electronic health records and EHR platforms. And so first, looking at age-adjusted rates of COVID-19 cases by vaccination status, this slide is showing that case rates in people with a primary series increased during waves associated with the Delta and Omicron variants. Case rates for unvaccinated people have always exceeded those among vaccinated people. In July, unvaccinated people ages 5 and older had a 2.4 times higher risk of testing positive compared for SARS-CoV-2 compared to people vaccinated with at least a primary series. And then these are age-adjusted rates of hospitalization by vaccination status. So now the COVIDNet data among adults 18 and older, and inclusive of receipt of a booster dose. Hospitalizations for COVID-19 have been consistently higher among unvaccinated than vaccinated people over time, of course. And in June, unvaccinated adults ages 18 years and older had a 4.6 times higher risk of COVID-19 associated hospitalization compared to those vaccinated with a primary series and a booster. And then lastly, here are age-adjusted rates of COVID-19 deaths by vaccination status and receipt of a booster dose. And in July, unvaccinated people 5 and older had 8 times higher risk of dying from COVID-19 compared to people vaccinated with a primary series and a booster. And this represented a decrease in the rate ratio from earlier in the year, possibly related to waning immunity and increased community transmission of Omicron sublineages, as well as other potential factors. Here are death rates by vaccination status according to receipt of first and second boosters among persons aged 50 years and older. These are data from April through July. And you can see in July 2022, people ages 50 and older who had received a second booster dose had a 14 times lower risk of dying of COVID-19 compared to unvaccinated people of the same age, and 3 times lower risk of dying from COVID-19 compared with people of the same age with 1 booster dose. So these data are suggesting that getting a second COVID-19 vaccine booster can enhance protection that might have decreased over time after receiving the last dose. And I'll also add that I spent a lot of time showing these data for cases, hospitalizations, and deaths by vaccination status with the rates and the rate ratios, because really what we're doing here is using surveillance data to make interpretable messages accessible to promote vaccination as a public health intervention. And so I'm mentioning the COVID data tracker again, because all of what I showed is available there. The data are updated monthly, and continuing to get uptake of booster doses, and now the bivalent vaccine will require public health messaging. And these are the types of statements we can make using rate ratios to talk about relative risk. Okay, just a few more slides. Here, wanted to summarize risk factors for severe COVID-19 illness. As I've said, unvaccinated people are at a much higher risk of severe COVID compared with vaccinated people. Most vaccinated people who get severe COVID-19 illness have multiple risk factors, including older age and underlying medical conditions, particularly immunosuppression, but also diabetes and chronic kidney, lung, cardiovascular, or neurologic diseases. And of course, antiviral drugs can help reduce the risk of severe illness, and particularly in people at higher risk. And I think we have more work to do to promote their use routinely. And so in summary, CDC continues to monitor emerging variants like the sublineages of Omicron, including their prevalence and the impact on disease incidence and severity over time. Racial and ethnic minority groups have been disproportionately affected by COVID-19 associated hospitalization and mortality. These inequities have decreased over time, but have not been eliminated. Recent trends show evidence of increasing severe illness, including hospitalization and death in the oldest adults and people with underlying health conditions. Current vaccines offer protection against COVID-19 illness and death. And so, as I've said, it's important to stay up to date with vaccination, including receipt of all booster doses in eligible populations. And therapeutics and multiple other prevention measures should be used to protect people at a higher risk of severe COVID-19 illness, regardless of vaccination status. That's all. Thanks so much for the opportunity to present.